Hello, I'm Dr. Harris, and this is me performing my hip and groin exam. Hi, nice to meet you. I'm Dr. Harris. Before I start any examination, I'm going to wash my hands. What I'm going to do today is examine your hip and groin. So first of all, I'm just going to get you to start by walking. I'm going to inspect the area, get you to do some movements and some other things as well, if that's all right.
That's fine.
Great. Before I start, have you got any pain anywhere?
No.
No, good. Okay. So the first thing I'm going to do is get the patient to walk, so I can assess their gait. So if I just can get you to walk between the two walls. So I'm just inspecting the patient's walk, looking for any abnormality with their gait, such as an antalgic gait or a Trendelenburg gait. I can't notice anything at all. Great, you could just stop there for me. If there was any abnormality to the gait, I might want to inspect further things like their shoes, looking again to see if they use any walking sticks or any assistance because of their gait or any abnormalities. While the patient is standing, I'm going to inspect quickly from the front, so I'm looking at their hip and groin area. For the purposes of the video, the patient is appropriately exposed, but with a patient in real life, I might want to have a closer look at the lateral hip area or the groin, so I might expose the patient more. So again, I'm looking at the patient's stance to see if there's any abnormality there. Again, I would look at the lateral hip for any scars at all, of none of which I can see, if I can get you to turn around. Again, looking for the alignment of the pelvis, and again, looking appropriately for any scars in particular. That's great. If I can get you to lie down for me, please. So I'm just going to continue to inspect, just look at the position of the legs whilst the patient is lying down supine, and again everything appears normal. So next I'm going to move on to palpation after I've inspected. So I'm just going to feel around your hip area to begin with, so all your bony bits, alright, and there's no pain?
No.
No, okay. So first of all I'm going to start palpating over the anterior superior iliac spine, moving down onto the anterior inferior iliac spine, and then moving down onto the pubic symphysis for any pain. Is that okay? Good. I'm now going to move over and feel over the iliac crest, and down onto the greater trochanters and surrounding areas. There might be pain over the surrounding areas if there was a bursitis. Is there any pain there at all? No. Great. And if I can get you to turn on your side, facing the window, I'm just going to palpate their ischial tuberosities for any pain at all. Is that all right? Yeah. Lovely. Turn back onto the front. With regards to the patient's groin, again, I'm not going to expose the patient any further for this video, but I'd like to closer inspect the patient's groin area, looking for any previous scars that they might have had, and looking for any obvious hernias. Again, if a hernia was suspected, inspecting the patient whilst they're in a standing position as well would be useful. So again, I palpate over the groin area, feeling for any lumps or bumps, and also palpate for the femoral pulse on both sides. And if I did suspect a hernia, I might palpate over the area and ask the patient to cough for a cough impulse as well. So this is the end of my palpation. So far there's been no bony abnormalities or any abnormalities felt within the groin. So next I'm going to get on to the patient to moving their hip joint. So I always like to get the patient to move the joint actively first and then passively with my assistance. So first of all, we're just going to get you to flex your hip joint, so that involves keeping a straight leg but bringing your leg back up towards you. So assessing the range of movement at the hip inflection, which is good, and back down, and then the other side for me, please. Excellent, and back down. So then I'm going to look at abduction of the leg. So if you keep this leg straight and bring it out towards me. Lovely. You get it any further? No. Lovely, and back towards you, and then back over the other leg, crossing over your legs. Good, and relax, and then do it with your other leg. So taking the leg away, and then over towards me. Excellent, that's fine. So I'm going to perform these movements passively for the patient. So I'm going to bring your hip into flexion, so bringing your knees up towards your chest. So slightly more range of movement passively. Again on this side. Lovely. And then I'm going to assess abduction. I'm just going to place my hand on the patient's hip just so it's stabilised, so I know that all the movement's coming from the hip joint and not from the pelvis moving. That's good. And then adduction, so crossing the legs over. There we go. And then abduction. And then adduction. Good. I'm then going to move on to moving internal and external rotation. It's quite hard to get the patient to do this actively, so I generally just do it passively for the patients. So I'm just going to bend your knee up towards your chest, and then I'm just going to move your ankle inwards. So this is looking at external rotation, and the ankle outwards, internal rotation, which is full range of movement in this patient. Again on the other side, so external rotation and internal rotation. If there was any suspicion of any labral tears and extremes of range of movement, I could palpate over the hip joint while performing this passively, and a positive test for any labral tear would be a pop or click. If I can get you to turn onto your front for me, please. And if you could keep your leg straight and raise it up in the air for me backwards. Excellent. And then the other leg. Good. That's brilliant. And I'm just going to do that for you. So bringing the leg up, keep it straight for me. Good. So there's good extension on both sides. That's brilliant. You can turn back over for me. So I've assessed range of movement in the hip joint, but I also just want to assess power as well. So with regards to flexion of the hip joint, it's performing a straight leg raise, so keep your leg straight and lift it up towards you. So there's good power in hip flexion on both sides. In terms of abduction, get the patient to move their legs outwards and then press their legs inwards. Good, and then bending the knee up. And for external rotation, pushing into my hand, thank you. And for internal rotation, pushing into my hands in the other direction. So the patient has good power in all range of movements. I could also get the patient again to turn on their back and assess power in an extension, but I won't do that, and obviously I should assess power in both legs. So after completing range of movement and power, I'm going to move on to special tests. So first of all, I'm going to get the patient to stand up again. The first special test I'm going to do is the Trendelenburg test. So this is looking for any weakness in the hip adductors. So if I get you to turn your back towards me. So what I'm going to get the patient to do is stand on one side. So if I can get you to stand on your right leg for me, please. So whilst the patient is doing that, I'm looking for the alignment of their hips. I want their hips to remain stable and level. The opposite side might even go up slightly. What I don't want to see is dropping of the side that the patient is not standing on. If this happens, this would signify that there's weakness in the adductors in the leg that the patient is standing on. So if there was a drop in the left hip, it would mean there was weakness in the right-sided adductors. I would also get the patient to perform this test standing on both legs, but I won't today. The next test I'm going to do is the stalk test, and this is looking for any sacroiliac joint dysfunction. So again, I'm going to get the patient to stand on their right leg, and I'm here behind you. If you just lean back slightly for me, please. And do you find you have any pain in the back of your pelvis here? No. So this test would be positive if when the patient standing on their leg experiences pain in the sacroiliac joint on that side that they are standing on. So in the case of this patient, it's a negative test. Great, that's fantastic. You can lie back down on the bed for me. There's three special tests that I'd like to perform with the patient lying down. The first is the Thomas's test, which is looking for any hip flexion and contractures. So what I'm going to get the do is just patient do is to shuffle down the bed a bit more so they're slightly more flat. What I'm going to do is if you can pull your right knee up towards your chest and hold it with your hands. So I'm looking, whilst the patient is doing this, that there's no excessive lordosis in the spine to compensate for doing this. and that their other leg is remaining in full extension on the bed. If there was any problem, any contractures with the patient's flexors, then when they flex their knee and the hip up, they would find that this leg might come off the bed or come into slight flexion at the knee. That's great. So if you relax that leg and then do it on the other side. So again, assessing that there's no excessive lordosis in the patient's spine and that this leg is lying flat on the bed, so there's no problem with this patient's hip flexors. That's great, thank you. In those patients who have problems with tight hamstrings as well, we can assess this by bringing the patient's knee up to 90 degrees of flexion and then extending the leg. This patient has very tight hamstrings and there's limited extension at the knee because of this. This is relevant to the hip exam as patients might experience hip in this generalised region from problems with their hamstrings. So I'm going to perform that on the other side. So 90 degrees of flexion at the knee and then straighten the leg. So this leg is slightly better, but there's still a lot of tightness in the hamstrings. The last test I would like to do is Ober's test, which looks at the iliotibial band, and you would perform this test if you were suspicious if there was any tightness or any popping in the hip. So this involves getting the patient to lie on their side, if you lie on your side towards the window, with your legs on top of each other. What I do is flex the knee slightly and extend the leg, and then what I'm going to do is drop the leg down onto the bed. The leg can fully reach the bed and lie flat on the bed. If there is any problem with the iliotibial band, the leg would struggle to reach the bed and we would know that there was tightness there. That's great. And again, I would perform this test on both sides. That's great, you can lie back on your back. To complete my examination of the hip and groin area, what I would like to do is assess the patient's neurovascular function within their lower limbs. So in terms of vascular supply, I would start off by palpating the femoral pulses in the groin if I haven't done so already, moving on to the popliteal, the posterior tibial and the dorsalis pedis. I would assess the capillary refill in the feet, and also just feeling the feet generally for heat, warmth, looking for any abnormalities in colour because of circulation. In terms of neurological examination, I would want to assess tone, power, reflexes, coordination and sensation. So I'll do that briefly now. So just relax your legs. I'm just going to move them and roll them from side to side. There's no increased tone in the legs, and now I'm going to assess power. Keep this leg straight and lift it up in the air for me. Keep it straight and push it down into the bed. Lovely. Bend this knee for me. Kick me away on the side. Pull me towards you. Back down straight. Bring your foot back towards you. Keep it there. Push down like a car pedal. And then do that with your big toe. So bring it towards you and back down. So this is assessing power in all groups of the leg, and there's 5 out of 5 power present, but I'd also obviously examine both the right and the left legs. Moving on to sensation, checking the dermatomes. Can you feel me here?
Yes.
Here.
Yes.
Here.
Yes.
Here.
Yes.
Here.
Yes.
Here.
Yes.
Lovely. And coordination, if you place your heel on your knee and drag it down your shin backwards and forwards. And the other side. Lovely. The final thing I would want to check would be reflexes. Unfortunately, I don't have a tendon hammer, but I would check knee, ankle and plantar responses as well. To complete my examination of the hip and groin area, it's always good practice to examine both the joints above and below. So in this case, it would be the spine and the knee. And in summary, I've assessed the patient's gait, I've inspected for any equipment that he might be using to compensate for any hip problems such as sticks or orthotics. I have inspected the area looking for any abnormalities. I've palpated the bony prominences as well as palpating the groin. I've got the patient to perform movements of the hip as well as assessing power of the hip. I performed special tests looking at sacroiliac dysfunction, any abnormalities in the hip adductors, as well as hip flexor contractors and any hamstring problems, as well as the iliotibial band. For a complete exam, I performed a neurovascular examination of the lower limbs and completed by saying that I would also examine the spine and the knee. The patient appears today to have no problems with their hip, and that completes my examination. Thank you.